pleasure to be with you, Rob, and to be part of the NetSmart Expert Witness family. Expert Witness there, I've spent too much time in court already. Expert panelist. Thank you, everybody. It's great to be with you this afternoon. I appreciate you spending time with us. As we did in the last webinar, I tend to do a 3 to 4 minute introduction to where there's no slides moving, so please don't panic if you don't see things moving on the screen. And with that little introduction, I'll go ahead and get started here. We know our 5-star ratings are a really good beginning, but they're really not enough to survive the new alternative payment methods being introduced. Now, the introduction of these methods started back in 2005, reinforced again in 2007, and then again with the Affordable Care Act, and in 2014, the Impact Act. These reforms that we're looking at, such as value-based purchasing, conditions of participation, and HHGM, actually started back in the 1980s when hospital systems started to get the DRGs and payment reforms and different things that were happening with the hospitals. That moved into the post-acute arena shortly thereafter. And we've been herded in a direction with STARS outcomes, pre-claims review, value-based purchasing. And yes, it does feel like CMS moves like a thundering herd of turtles, but they do really arrive at some point and they stay. We know the new conditions of participations took forever to get here, but we're going to be accountable for them in January. HHVBP penalties will also begin with January, and thank goodness the first year's penalties are intentionally light. If you ask any hospital administrator or CFO who's been going through this since the 1980s, they'll tell you just how easy it is to wind up in the penalty box the next year after hitting the bonus rounds. So people are failing still to realize that value-based purchasing is a competition for the best seat at the table, and few home health agencies are realizing this. 50% will soon feel a slight sting, with a significant portion taking their status for granted, and about 14 months from today, they'll be on the other side in the penalty box after being on the payment side of things. These new payment models are going to force providers to focus on post-care cost margins during the start of care visit. This is how the hospitals learned how to survive. So pre-care delivery case mix enhancement will soon be a thing of the past. It's going to be looking at your margins that are left over after the provision of care. This margin that's left over must be analyzed during the start of care and research visits, and this is where you're actually going to glean your profit margin. We know that HHGM will be with us in due time, but not with the parameters we see today. And this kind of worries me. As one who used to work for CMS, I can tell you the data used to build the HHGM system and analyze the value-based purchasing system and the PPS systems in general tend to be about 3 years old. So as HHGM is put into pasture for a temporary period of time, the consultants who build the model now have 1 more year of data. And as this data is starting to accumulate and be analyzed, we're seeing a whole bunch of successful value-based purchasing candidates and do believe that value-based purchasing will affect HHGM. We're seeing the people with value-based purchasing bonuses now having 35, 38, 40-day lengths of stay, and their payments are dropping down as well as their profit margins going up. The moment HHGM consultants see that they can actually get below the $1,700 thresholds that we anticipate with HHGM, we're probably going to see something in the high 1,500s, low 1,600s for reimbursement versus the 1,700. So if you want to know whether you're positioned for HHGM, pull your Casper agency patient-related characteristic reports, get the 3-column version, not the 2-column version, go to page 3, and in the left-hand side, look at your average length of stay. Every day above the national reference mean of 58 point whatever days means the cost of care you report to CMS, and again, every day above 58, is not in alignment with the value-based purchasing or HHGM quality and cost mandates. Remember, average is not good enough anymore. High volume, large census, low value care models are being replaced with high acuity, outcomes driven, rapid cycle care. This mimics the restructuring of the hospitals, and the acute care reforms basically went from a fill the beds and then it turned into empty the beds almost overnight. We will be emptying out our censuses in order to reduce our cost, reduce our length of stay, and this will happen very quickly because if we don't mirror what the other providers such as the hospitals, SNFs, LTACs, IRFs have done previously, we're going to be put out to pasture. Remember that the CMS payment reforms changed the clinical behavior of physicians, nurses, and paraprofessionals, and the focus of hospital administrators and CFOs as well. And again, remember, the primary change, the one that was easiest for us to see, was that the hospitals were a beds full versus a value of care beds empty. And this literally changed the entire delivery from procedure, recovery, discharge to procedure, discharge, recovery. This is one of the reasons we see patients coming into the home health arena so much sicker and with much more acute acuities. CMS watched this change from procedure, discharge, recovery develop. They examined the innovations that were born of it. CMS knows that when they put cost before quality, they were able to find people who would go out and figure out new care delivery models and methods that met their expectations. Those who didn't basically retired and fell by the wayside. As a nurse experiencing this change when DRGs came in and not liking it one bit, I joined my peers on the picket line marching up and down the sidewalk with my little sign, jumping up and down and protesting. Well, a whole lot of good that did, because here we are today with DRGs, and DRGs really do define the content of the patient episode, not the clinicians providing the care. Nowhere in the Medicare certified acute care continuum does a nurse walk up to a hospital administrator and demand the patient stay an extra day or two. It just doesn't happen. Agencies I speak with today say I'm confused by all the Medicare changes and find keeping up with them impossible. And I agree. But is it CMS's fault or ours? If it is to be our fault, there's only one change necessary to address the COPs, HHVBP, and HHGM in a comprehensive, cost-effective manner, and still obtain margins identical to the first 2 years of the PPS. Most of you who have followed me over the last 20 years know my mantra: get the OASIS done and documented while in the home. Your OASIS assessment process, the one that leaves us charting at 6, 7, 8, 9 o'clock at night, which for the past 20 years has been the norm, is basically coming in 30 to 50% light in revenue and acuity, and then we transmit that data. So moving towards the hospital model, where all utilization review was centralized into a core team of people who utilize best practice care planning, which we'll discuss a little bit later in the presentation, the hospitals achieved the triple aim of CMS: cost, quality, and delivery of care. So think about it. Again, Medicare Home Health is the only Medicare certified provider left who sends one person by themselves into the home with no support or accountability to determine the acuity, case mix, outcomes development, revenue integrity, care plan, visit frequency, cycle, and duration without any support whatsoever. And then we turn around and we complain about the results. So CMS has witnessed the results over the past 20 years and is now eradicating the payment system that supports it. And I still run into agencies who desperately grasp to keep a hold of that. The care delivered in the acute care venue is data-driven in every respect. It is completely governed by a utilization review team, which again is a centralized group who authorizes best practice, cookie-cutter type care, which is then carried out by the clinical team. Home health agencies wishing to continue to do business will learn many of these skills or lose market shares as their competitors learn their skills. and those who cannot will simply not be able to fly with this. Sorry for the length of time to the first slide. So as we move into volume and value, and we transition from volume to value, CMS is not the first group of people that has talked about this. The Metropolitan Life Insurance Company was one of the first entities to discover this. MetLife discovered that providing home health care to its policyholders had the strong potential to prolong life. This would allow MetLife to continue collecting premiums, continue to turn a profit, and abstain from paying out death benefit payments in an attempt to get better results. MetLife basically at this point found that providing more care did not improve outcomes. MetLife sought to limit visits and eliminate the type of personnel services offered, and ultimately MetLife discontinued home nursing services, determining it to be unprofitable. I'm actually thinking some of the MetLife people may have gone to work for MedPAC. So during IPS, the average number of visits per episode was in the high 50s to 60s, with many episodes having 70 or more visits. As IPS transitioned to PPS, the number of visits dropped down into the 30s and 40s, and with case mix rebasing over the past decade, today's average number of visits is somewhere in 12 to 15, with the average number of therapy visits per episode, per discipline of therapy per patient being approximately 7.24 to 7.6 for the past 15 years. Bringing in the HHGM 30-day episode being implemented, MedPAC estimates there will be considerably more LUPA episodes than we see today, far fewer late episodes than we see in the current PPS model. There will, however, be enough money for therapy if the OASIS is performed in the home along with quality assurance and the accurate acuity is taken into account. As I talk to providers, many of them are saying, I'm just going to double down on the recertifications to keep the cash flow. They're going to hold on to what they've been doing for the past 20 years. And if you continue to double down, the ADR and ZPIC problems are going to come because of the rapid cycle data-driven patterning that will occur is going to be a real problem. Either we will learn how to work inside of these parameters or we'll deal with the ZPICs. Give you an example. Improper recertification and utilization in rapid cycle 30-day episodes consolidates 12 months worth of data patterning into 4 to 6 months, rapidly triggering waste, abuse. I hardly ever see fraud. I see a lot of waste and abuse, and that stuff is picked up by the software the CMS contractor community uses. Again, all of this contradicts the finding of insurers and CMS in the early years of the home health program. So moving into present day. The new alternative payment methods are designed to assure that payments for services are made and they are correlated to a similar or same acuity level in the setting of the entire Medicare certified continuum. The entire continuum. So an example would be a therapy visit reimbursed in the inpatient rehabilitation facility setting would have the same acuity as a visit in the home health agency. Unfortunately, home health agencies routinely fail to meet this acuity and this cross-settings threshold. And this is one of the primary drivers behind removing therapy bonuses in the HHGM model and not rewarding high utilization in value-based purchasing. There's no continuity in payments between acute and post-acute. And what we're seeing is a trend that still says, can I bill for that? When somebody projects a different way of doing things, the first response is, can I bill for that? And we're still holding on to an assess and treat mentality and care planning off of subjective assessments. This results in subjective assessments, not OASIS-driven assessments that are coming out of the grouper, and we routinely see 2 to 3 visits wasted per episode, and they're used for very low-tech things like fall prevention, dietary teaching, and many things that are just not even inside of the plan of care or related to the diagnosis that was listed on the referral. 1 week 9 recert, 1 week 9 recert, pretty much obsolete. This type of care is what the home health value-based purchasing, the new COPs with their care planning, and the interim time point management of the care plan is designed to eliminate. And then again, the 30-day episode is not going to work anymore with this 1 week 9 pattern. When you look at the ABT research associates that have put out, they're telling us that 70% of all episodes that are currently performed are late episodes, meaning third or greater episodes, third, fourth, fifth, sixth contiguous episodes. And the primary manner of getting to those episodes are 1 week 9 recert, 1 week 9 recert. If we look at the 1 week 9 pattern, this pattern actually 7-8 years ago used to be 2 week 9, and due to the reduction in case mix and payments to us, we've now gone into the 1 week 9, and occasionally I've seen in Florida and Oklahoma quite a few agencies going into every other week visits, and that just really flies in the face of all these Medicare reforms. So moving on, sorry to drone on about the 1 week 9, but if 1 week 9 and a large family of recertified patients is the core of your business, you need to stop, take a time out, and look very hard at what you're doing. So skilled care, let's go down to skilled care for a second here. A lot of times we're using skilled care when the OASIS data clearly demonstrates the patient's far more appropriate for ambulatory services. And again, I'm going to reflect on the data that was collected by the nurse in the home and generated and then turned into CMS. I know, based upon 20 years of doing this, that nurses can identify the acuity inside of the episode, and they see the acuity inside the patient, but 50 to 60% of the nurses out there today do a horrific job at translating that acuity into the OASIS assessment, kind of the round peg, the square hole kind of a deal. What happens is when this is improperly done, and if you think about it, every year for the past 10 plus years, we've had a decrease in payment. That decrease in payment makes it harder to score the OASIS. When I say harder to score, it's harder to get from C2 to C3, but the clinician in the home still sees C3, turns in a score that represents C2, and doesn't get enough revenue to basically cover financially the number of visits that are about to be set forth. So you bankrupt yourself in 1 to 2 episodes, affecting 5 or 6 episodes around you. No longer can we just basically take our OASIS assessment for granted. Using the wrong discipline, we see a fair amount of this. And just again, the volume model incentivized us to fail and provide more care, when in reality, nurses were basically trained to help people get better, not hold them on. So as we're moving through here shortly, couple months we're headed into the new COPs and again the value-based purchasing penalties. The present day markers for success are focused on average daily census. Okay, average daily census doesn't really help you as far as value-based purchasing goes on, because it's about the number of wraps and finals they submit on a weekly basis or a daily basis, not the census. So agencies whose markers for success are average daily census, a high length of stay, and then depending on therapy utilization, are really going to have a hard time moving through in value-based purchasing. And I know this flies in the face of assisted living facility stuff. We're simply going to have to learn how to work inside of CMS's metrics. No PEPs or LUPAs is a measure that agencies love to hold on to. And as we move into value-based purchasing and HHGM, you're going to see an increase in PEPs or LUPAs, and that's just the way the payment system's moving. Anybody with a recertification percentage of 15% or greater needs to stop and take a very hard look at what's going on. Once again, length of stay metric, anything above 58.x days represents a higher cost of care, a lower level of efficiency, And quite honestly, a lot of this turns out to be agency-centric, not patient-centric. So as we go into the future, Medicare home health should be better defined. This is a mantra that the MedPAC folks have been on for a long, long time. Home health payment should home health payment should match the care modeling for the same diagnosis and acuity as other post-acute providers. This is something that we just talked about previously, and agencies who depend on the 6, 14, 20 therapy visit bonuses, and more than 50% of the agencies state they cannot live without these bonuses, are going to need to learn how to finance their operations without these extra payments. And once again, getting the OASIS done while the nurse is in the home, interjecting live quality assurance with real-time service utilization review and quality centralized care planning that parallels hospital practices, SNF practices, is what will get us there. Okay? Referral source, timing, clinical grouping, clinical functioning, and comorbidity, all of these things have to be identified during the OASIS visit while the nurse is in the home. Live QA makes the difference. The interesting thing is, live QA takes about 20 to 25 minutes on average, and post-assessment QA tends to take about 3 hours on average. So we can already start to see that service utilization review performed while the nurse is in the home in collaboration with the nurse while the nurse is in the home now can give us service utilization review based on OASIS metrics, not eval and treat. So again, quality assurance activities must change the way we do our admissions and recertifications, and the ability to move forward with metrics as far as reducing ED and hospitalization usage are going to be dependent upon identifying what's happening right up front and making it work. Why is all of this so important? We run data on people all day long, every day, and we have a revenue integrity report that we run for people, and we see episodic cost overages in labor alone of $381 on average. On an average census, this is going to run about $1.5 million per year, and when CMS looks at the utilization and cost report data, they see high margins are available and possible, but they also see us wasting a great amount of labor. Again, the 30-day episode, if we start training ourselves to move towards the 30-day episode now, and we're able to decrease our nursing visits, consolidate more into the visits instead of showing up and just doing 1 or 2 things inside of a visit, now we start doing 3 to 4 things in a visit and following up on the next visit, we're able to get the majority of our work done in the first 30 days. This parallels the drop by almost 50% during the last 30 days of a cert period. When you look at value-based purchasing and the effect it has had on the industry, we're front-loading visits more than we ever used to. When we're looking at the quality improvement networks that have been working with us the past 10 years, we're front-loading more of our care into the first 30 days. And again, 50% of the agencies are doing a fantastic job at getting the majority of the patient's needs met within the first 30 days. And again, there's the converse to that, which is where 70% of the episodes in home health are 3rd or more contiguous episodes. 3rd, 4th, 5th, 6th. That's going to be a problem. That is not a sustainable practice. And then again, almost half of the agencies out here that Medicare is looking at through the data that they're analyzing, they show a start of care date as listed on the OASIS, but they don't show billing of a wrap until around day 30 of the period. If you go back about 15 years, and some of you have been in home health that long, many of you may be new, if you go back about 15 years, we were allowed to go 30 days until we had a signature on a plan of care. And a lot of folks took it up to 27, 28, 29 days. And the conditions of participation were changed. The transmission of OASIS data was changed. And you can, if you look back carefully, see where we've gently been herded along the path and moving forward in this direction. So again, referral source and payment that includes diagnosis and comorbidity are now going to be required to make it easier to identify the reasons for home health. So as we move forward, we've got to get our OASIS done in the home, working with collaborative quality assurance. Moving forward here. The future. As we move forward, the markers for success are not going to be average daily census. They're not going to be recert rates of 15, 30, and 40%. The markers for success are going to be the ability to work with a primary referral source who is an acute care provider. The acute care providers and their consulting firms are now looking at the cost of care from home health agencies. The reason this is because somewhere around 2020 to 2022, the hospitals will probably be your payer. In other words, hospitals are going to be given X amount of dollars for the entire care continuum. We haven't seen much published about it yet, but we will down the road. So as the hospital consultants start to look for value in providers, they're looking at your cost of care, they're looking at your outcomes, they're looking at your 5 stars, 4 stars, 3.5 stars, and we're now starting to see many, many hospitals drop anybody as a partner who's less than 3.5 stars. I would imagine very quickly in the value-based purchasing states that anybody less than 5 or 4.5 stars is in jeopardy of losing their hospital partnership, because the hospitals now have a larger pool of higher quality, lower cost partners to choose from. I know it's not a very nice thing to say, but that is the way life is. Hospital-like staffing, 7 days a week, noon to 9 shifts. Far too many missed visits are going on, and quite honestly, if we're missing visits, how connected to our patient are we? Missed visits tend to happen most frequently in the 1 week 9, every other week 4, or tail end of what's going on. And CMS sees this. So as we move forward and we start working more and more with the acute care provider, it's very common to start seeing 7 day a week, noon to 9, ready to start that IV and things moving forward. I remember driving through Baltimore, Maryland, and seeing a home health agency advertising on a billboard, start a care within 4 hours. Give us a call, we'll be there now. Rapid cycle referral. We're going to see patients coming to us with a much higher acuity, much more sick than they've ever been before, and we're going to see what we now know as the silver tsunami coming down on our shoulders. And these people are not going to be able to wait 24 to 40 hours to get a nurse out. We're going to need to get somebody into the home within 4 to 8 hours of the referral in order to keep them out of the hospital, basically to continue their IV antibiotic therapy, what we have going on there. With this level of acuity, with this volume of patients, again, we're needing to get all of the OASIS QA done in the home in real time and send the nurse out of the home with no more documentation to do. This actually allows, and we're seeing this already in our practice, this allows 4 to 5 OASIS assessments to be done, plan of care implemented, medication list reconciled, and a RAP submitted at the end of the day with a referral, with a plan of care sent to the referral source, and the nurses do not document after 6 p.m. Increasing your capacity for care by being able to do 4 to 5 OASIS per day in a team-like manner, a care team manner, is allowing you to work in the manner the hospital works, and again, increasing the capacity of care where there's a recruitment and retention nightmare in home health. We're not growing nurses on trees. Nurses are tired, they're burned out, they're thrashed, yet the drive for quality and reduced cost is becoming greater and greater and greater. There is simply no other acceptable way to increase capacity, reduce cost, and increase quality without doing this QA in the home in real time. Care plans initiated during the start of care visit and soon to be fewer recertification visits allow us to help patients regain their health faster, take control of their health, and become responsible for their own health conditions. If we're waiting 1 to 2 days to get out there, and then it takes another 3 to 4 days to get a plan of care implemented, we've already lost a major portion of the critical 2 weeks that it takes to keep somebody out of a hospital. Those first 14 days are where the rehospitalization starts, and most of us are not initiating a solid care plan during the start of care, and then having 3 to 4 goals to follow up with the patient. And very few agencies are monitoring the evening of the start of care with a phone call while we're waiting for that next visit, whether it be the next morning or the day after. And again, utilization based on OASIS acuity data. Nurses are amazing. I love nurses working in the field and the compassion and the eyes that they have, because they see just how sick the patients truly are. But translating that illness into the OASIS, which actually does determine the level of care, just like the DRGs, until we learn how to do that better, we're still going to have challenges. So again, rapid cycle unduplicated census, turning over equals outcomes. This is what we're basically rewarded for. Outcomes equal income. Our length of stay being 30 days or less, or somewhere in the 40-day range, is going to really make a big difference in your cost of care. And when you put agencies side by side and you simply look at their length of stay metrics, the efficiencies and the relevant financial profiles that go with that are amazing. You can see it very clearly from one to the other. And again, no reliance on therapy income, and recertifications are going to wind up being fairly rare pretty soon. So moving forward, practical steps to being a success in an industry filled with change, confusion, frustration, anger. Sometimes we just feel like we're swimming through the mire and the muck, and it really does get a little bit tiring. What do we have to do to prepare? Well, we've already talked about the acute partner accountability, and our outcomes reporting is going to be really critical. But our rehospitalization plan of corrective action, let's dwell on this for just a moment. During the process that we help people with, we treat the resumption of care visit coming back from the hospital as an incident report. It's an incident because our referral source trusted us to keep that patient out of the hospital. The CFO does not need to be paying any more penalties due to our lack of sophistication or ability to support their mission. So a plan of corrective action for every patient that was rehospitalized that week is sent out to the referral source. This preserves the relationship. Yes, we're meeting their needs. During the resumption of care visit, the live QA interactive OASIS assessment determines, was it a patient failure, a system failure, a home health agency failure? Did we have the right DME? Did we not have the correct medications? And you can just take that and extrapolate it out in many different ways. Patients must have accountability. And there's just the ability to say there's no willing, able caregiver. That's fine. We're not able to rely on that anymore the way we used to. And the successful agency is going to be grabbing somebody by the elbow and dragging them across the room and saying, hey, you need to get involved with this. This is not a choice. If you're not able to get involved with this, maybe your patient or parent is not going to be able to stay in the home environment. So must have patient accountability, patient caregiver accountability. And we're actually seeing a couple hospitals in Texas right now have patient contracts for compliance. And this is kind of strange. We're actually seeing there's a 40% population who refuses home health after a discharge from hospital, who winds right back up into the hospital. And there's a couple hospitals that have those patients who are referred to home health listed in a database. The moment they hit the emergency room, they know that those people were supposed to be in home health, and they're able to confront them on the emergency room gurney, hopefully they're non-critical, and say, you don't really belong here, you're supposed to be in home health. And your home health agency, we know from experience, takes very good care of you. So documented patient goals and all of this is going to be really critical moving forward. And then field staff accountability. How is the OASIS being performed? And productivity. Are your clinicians only able to do 3 OASIS a day? That's not going to make it in the future. Management starts to control the agency instead of 40 clinicians from the front seat of their cars behind their windshield will control the agency. It's going to have to be a little bit of a reverse. And again, nowhere in the Medicare certified continuum does a clinician go out and make scheduling, length of stay, utilization, and care planning decisions without any support whatsoever. And computer support and business intelligence analytics are far too easily ignored by clinicians. So bringing it back in. And again, embrace your data. Medicare has, and I can tell you as a former CMS OASIS coordinator, the history of your business is written in your data. Again, the history of your business is written in your data, and it's basically everybody else's business to understand that data and use the data in a predatory manner to enforce compliance and basically enforce the conditions of payment. So doing end-of-episode audits or looking at Casper and Pepper reports is simply not enough. They're too old. And again, service utilization must be based on OASIS acuity if it's accurate, not a voluntary guesswork. And then data-driven length of stay. You will learn to use your OASIS data inside the start of care visit and abandon subjective opinions, which are seems right, feels right kind of things. If there is a change in condition, that's fine. You can go ahead and alter your length of stay and your plan of care, but only after the change has basically presented itself. And outcomes are going to be tied directly to a patient's elevated state of health, how long it took to get there, and the patient's satisfaction. So again, getting it right at the start of care. CMS uses the start of care OASIS to calculate medical necessity based upon the HIPS, the HERGs, and the grouper output, and more specifically, the treatment authorization codes. If that acuity is not correct during the start of care or recertification, or even during the resumption of care, it's very difficult to show improvement at discharge. So looking at the M questions during the assessment, not a day or two later, getting them right and not charting around them is going to be critical for getting your QAPI done. Episode timing, as we know, 70% of the episodes are late, and that's ABT and Associates documentation. We're going to have to be very careful about where we're at inside of the episodes. Coding is not going to be as critical as it has in the past to revenue because the payment models are now tightening up. We're getting less codes to code with on a yearly basis, and we have to be very careful about coding, therapy utilization, and quite honestly, submitting medically unbelievable edits. Medically unbelievable edits are specifically created when the nurse sees the acuity of the patient but is unable to translate that acuity into the documentation that you submit to CMS. It's not your written documentation, it's your data documentation. And then again, providing care that exceeds the acuity in the OASIS. How do we move forward and start doing that? We start getting it right during the start of care visit, okay? There's the walking, talking OASIS, and there's the sitting down and relaxing OASIS. And it seems like 50 to 60% of the OASIS we see is done on a couch. Agencies have no accountability for how the assessment is performed until they put the live QA component into that. If Mrs. Jones here walking with Nurse Jerry is asked, did Jerry walk you around the house? Well, Mrs. Jones is probably not inclined to lie. But if the patient being talked to up here is never questioned by somebody inside the agency, did Nurse Lisa walk you around? How do you know? The sitting on the couch OASIS gives a 30 to 50% loss in revenue routinely. And again, the clinicians who see the acuity absolutely insist on having 15, 18, 19 visits when they only brought in revenue for 6. And again, this is our live service utilization review that agencies will learn to start getting past this and through this. This is where we start focusing on getting patients better, faster, and moving them through the system. It's okay that they come back, but they need to move through the system. Now, when you're doing your QAPI during the start of care visit, it eliminates the need for back and forth corrections, and this adversarial loop really does get old. You're interrupting somebody in their workday. It's taking a great amount of time and labor. This adversarial loop takes about 6 to 7 hours by the time the OASIS is finally locked. And nurses tend to just get frustrated and say, I saw the patient, you didn't. Take what you've got, stop bothering me. So when we start doing this during the start of care visit, it drastically decreases charting time, and this is where the edge is given in recruitment and retention. I was specifically asked during the last webinar to just introduce the scribing process because it was so unique and different. So I'm just going to go ahead and just briefly go over this. So the scribe is somebody who's in your back office, who's working with a clinician in the field, and that clinician has completed the walking, talking OASIS because they've been asked and verified, not the clinician, the patient. So the scribe actually is working with the script, talking to the nurse with an earbud, and it's really kind of cool because the earbud allows the nurse to talk to the patient and the scribe can hear, and back and forth. It's very non-intrusive. So let me just give you a quick example. Scribe, tell me about the patient's GU-GI status. And the nurse's response. Mr. Smith's urination is quantity sufficient, pale yellow, and he has stress incontinence 2 to 3 times a week. He has daily bowel movements, denies bowel incontinence or constipation, and eats 2 to 4 small meals per day. Bowel sounds are normal times 4 quads. Experienced OASIS people understand that we just answered these 1600 series questions, and the scribe is able to fill in the GU-GI section of the OASIS assessment as far as the patient-centric assessment and moves forward. Here's where the live QA process and the scribing really starts to hit home, though, because the scribe and clinician review now start to work on the acuity-based staffing. And again, nurses really do see the acuity inside of their patients, but the grouper has gone through so many changes, and it's so difficult to get from C1 to C2, from F2 to F3, and get the revenue that's necessary to take care of the patient and put the visits in place. So this is a real life patient where basically we had a C1, F1 patient, and the quality assurance tool said because you have answered 92, 96% of the questions as 0, no acuity, you have a LUPA. And of course, the nurse talking to the live QA back in the office blew a gasket and said, oh, no, 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 no. This patient is very, very sick. And the live QA portion of the procedure during the QA process in the start of care visit during the home visit, sorry, I really jumbled that up, went through the QA tool, and within a couple of minutes, you can see the timestamps, within a couple of minutes went from a C1 F1 to a C2 F3 and gained 11 to 15 visits, which fit inside of the episode budget. Routinely, we see these acuities transmitted that really correlated budgetary-wise and medically reasonable and necessary-wise to 2 to 4 visits. This we see routinely submitted with this amount of visits performed, and the two don't correlate. So this is what live QA does, moving you through the system. Service utilization review and data-driven length of stay. Agencies will learn to utilize their metrics in the OASIS acuity, and the functional scores basically F1 should, could, may equal no therapy. Functional 1 may equal an eval and 2 or 3 visits to install a home exercise program, but functional 1 certainly does not correlate to 20 therapy visits, and we see this routinely. A clinical 3 score would mean more skilled nursing visits than a clinical 2 score. And again, the C1 F1 that we just saw a moment ago is probably going to be a LUPA. So the live QA and the ability to go back and forth and discuss what's going on uses the data during the assessment to drive the care, to drive the utilization, to identify the outcomes that are going to be improved upon, and then those outcomes are my target for moving forward. And again, primary-based diagnosis and evidence-based care are going to be critical. We're going to look at a 485 here in just a moment, and I'm going to ask, are these questions your 485 and locator 21 answer? What is the patient's diagnosis? Which of the interventions listed in your plan of care will actually keep the patient out of the hospital? Which interventions listed in locator 21 are most important? What should be taught first? And it's a dirty word in home health at times. When do I anticipate discharge? Discharge planning starts during the start of care visit. If something turns south and the patient has an extended period of care, that's fine. But every single Medicare certified continuum starts discharge planning during the admission visit. And then how does this care plan ensure I meet my outcomes for STARS ratings, VBP, and the different program mandates that are coming forward? So let's take a look at our care plan. This is a real example. We see this care plan over and over and over again. This care plan's talking about influenza and pneumonia vaccines, avoiding smoking, irritants and allergens, allowing people to smoke in the home. It talks about energy conservation, avoiding large meals, heart attack, UTI, communication skills, and this is the one I enjoyed the most. It talks about difficult to follow conversations, SN to instruct patient to wear proper footwear when ambulating, apparently due to the inability to follow conversations, annual eye exams, and high-risk medications. If I'm a nurse, I'm pretty clueless as to where to start. I'm unable to figure out what's going on and where my outcomes are coming from. If I'm a doctor, I'm looking at the people sending this to me like maybe they're a little on the disorganized side. So let's take a look at a diagnosis-based 30-day care plan, very simple and easy to follow. Okay, my skilled nursing visit is going to be required teaching for COPs, first thing right out of the gate. So I'm covering everything Joint Commission, ACHC, and CHAP is requiring, plus the new COPs. Skilled nurse to define primary diagnosis. It came across on the history and physical as congestive heart failure. Is this truly what we're in here for, or are there additional things to be working with? Skilled nurse to introduce zone tool for CHF management, review 30-day hospital admission. These things are now starting to make a significant difference in my progress with the patient, getting them healthier faster. And then now I'm moving in a predictable pattern between number 2 visit, number 3 visit, and number 4. If somebody calls in sick or gets hit by a bus, we know what number of visit we're on. We should know where the patient's been. We have the ability to reevaluate how they did and then move forward as needed. Hopefully that makes sense. So as we near the last slide here, everything really does roll downhill. Again, the hospital DRG model changed a $1 billion+ a year industry from procedure, recovery, discharge to procedure, discharge, recovery. Hospital length of stay decreased from 10 days to 3 days. I remember sitting in a staff meeting when we were told that, you know, that cholecystectomy that you took care of for 10, 12 days on the floor will now be discharged in 2 to 3 days. As a nurse, and being a young guy at that time, I sat there thinking to myself, who needs a new Mercedes? Who needs a new airplane? Because these patients need the care. Well, that was back in the 1980s and 90s, and the patients are going home today, and they're generally doing pretty good. So controlling labor costs with better outcomes is really the goal of CMS. And again, putting cost before quality, CMS has got 20 years of experience and data and empirical evidence that says this absolutely does work. So the specific concentration on reason for admission is where the hospitals went because they couldn't afford to take care of all the peripheral things. They would need to send them back out to the clinics and things to do that, and they did very well. And again, I know there's been a great deal of concern about HHGM. Please ignore it for a minute, because if anything's going to take you down, it's going to be value-based purchasing. Every single year, you have to do better than the year before, and better than all of the agencies around you. So in January 2019, the people who have received their bonuses in value-based purchasing have a target on their back, because everybody that doesn't get a bonus is looking to get back into that round. By the third year of value-based purchasing, this metric alone, value-based purchasing, is probably going to close 15 to 20% of the agencies. Then you bring in HHGM, and it just really is the icing on the cake. But value-based purchasing is the thing to worry about. The conditions of participation will demand an increased level of compliance. And I think agencies really, truly are going to be astonished at the level of compliance that's required in these different models. If you're not compliant, you're simply not going to be here. And compliance is basically going to be decreased length of stay, increased outcomes, decreased cost of care, and quite honestly, if most of the visits are already done within the first 30 days of the episodes that are out there, why wait to start doing 30-day episodes? Your margins will increase tremendously with 30-day episodes, many times to pre-PPS margins. By the time VBP and HHGM are kicked in, and you're now into a 30-day, 40-day episode, chances are you've already paid for your transition. Focusing on the referral diagnosis versus the eval and treat, fishing expedition, can I bill for that, can I find everything I can do, is going to help you get through these things up through here. And again, significant changes in care planning are going to need to be made. Centralizing your care plan and having the control of your care planning done by an internal team of people versus 20, 30, 40 nurses in the field is how this happens. Nowhere in the Medicare acute continuum do 30 or 40 people go out and develop the income, develop the care plans, develop the outcomes by themselves without assistance. When you look at how hospitals admit patients, they don't use business intelligence, they use teamwork, they use a care team approach. So as we move forward into these new payment models, we're going to be very well advised to look at where those who went before us have come from, how they got there, and where we're headed. So with that, I am 6 seconds shy of 60 minutes, and I'm going to turn this back over to Mr. Love. Thank you, Robert.
Well, thank you. Thank you, Michael. We do have some questions, if you don't mind sticking around and answering a few.
I'll do my best.
Okay. So early on in the presentation, Linda asked, do you envision our light tech dependent patients like Foley, G-tubes, ports, etc., who have researched LUPA episodes historically, will they no longer be appropriate home health patients?
I honestly don't see any LUPA appropriate patients having problems with long-term care. Most of the long-term care scrutiny comes from high-cost long-term care, where maintenance therapy and people are trying to say 12, 14, 16, 20 visits of maintenance therapy. When we're looking at the ports and the Foley casts, I think you're going to be just fine.
Okay. It was just a little bit ago, someone asked if you could give an example of a medically unbelievable edit that you mentioned.
Sure. I think anybody out there would agree that a functional 1 patient probably does not need 20 therapy visits. A clinical 1, functional 1 patient, where 95% of the OASIS was marked as a 0, would not need therapy visits. There's a little over 417 medically unbelievable edits, but I think that's the most easily understood one.
Okay. Okay. Let's see. Other questions are coming in. Let's see. I don't understand this question. I hesitate to read it out loud here. Lots of questions about recording, and the presentation is recorded. And in about an hour, we will send out a recording to the first presentation because a lot of people asked about that as well. But this recording will be uploaded, I would imagine, within a day. We'll get this done. Any other questions before we tie it up here today? Looks like we have contact information up here for Michael if you have any follow-up questions, and if we do get any questions after hours or what have you, we will address those offline. Just a couple questions here that are coming in. What do you foresee happening with wound care patients when you know upon admit that they cannot heal within 30 days?
Great question. And as I study the home health grouper model, I see more reimbursement for wound care than I've ever seen before, but I also see a decrease in the second 30 days. I think we've been nurses long enough to understand that the wound care patients that we're taking care of are going to take 3, 4 episodes of care, maybe 5 or 6 in the 30-day episodes. So the most intensive need is probably going to be necessary during the first 30 days, and then we're going to try and go into somewhat of a maintenance, although debridement and everything else causes changes in the wound. As we report those under the HHGM model to the grouper and through the payment house at CMS, it appears there is sufficient payment for that from what I see already. So I would embrace wound care. It's actually going to be reimbursed more fairly than it ever has before.
Okay. Yeah, actually, I think 3 questions came in all about wound care all at the same time. So I think a lot of folks are thinking like that. Well, good. Well, I think that's going to do it here. I think what we would like to do here is, if you have any follow-up questions, or will you take them via email, Michael?
Sure, happy to. Please put Devero webinar in the subject line.
That'll most definitely be helpful. And I'm going to wrap up the recording here.